I'm Jen Aliano, Director of GrassrootsHealth, and I'm happy to introduce this presentation and discussion with Dr. Weiss. Dr. Scott Weiss, MD, is a professor of medicine at Harvard Medical School, professor of environmental health in the Respiratory Biology program, and a physician in the Division of Pulmonary and Critical Care Medicine at Brigham Women's Hospital. He has received many honors and awards and was recently identified as part of the top 0.004% of biomedical researchers in terms of the scientific impact of their work. Some of his long-standing research interests also include the fetal and natural development of asthma, the role of vitamin D supplementation during the prenatal period on various outcomes, personalized medicine, and the development and application of new technologies into clinical practice. Welcome, Dr. Weiss.
I'm going to start by talking about some of the vitamin D research that we did, which led up to the VDAR trial in terms of how we actually got into this. So the very first thing was that we identified the vitamin D receptor gene as a potential locus that was linked to asthma. And that was a genetic study where we demonstrated an association between this specific gene, vitamin D receptor, and the phenotype of childhood asthma. And then rather than investigate that in genetic effect right away, what we did is we did a couple of observational studies. So these were longitudinal observational studies where we measured the intake of vitamin D in pregnant women and looked at the effect of that vitamin D intake on Weiss outcomes in their children. And we did two of these studies with different levels of vitamin D intake. But what we found was that the higher the vitamin D intake in the mother was, the more likely it was to prevent asthma in the offspring. And so we used these two findings, the findings from the two observational studies and the genetics, to help us write the trial that was became VDAR. So just a few background pieces of information that, everybody knows that there are endocrine effects of vitamin D that are linked to bone health. But what people don't appreciate is that vitamin D has a developmental component in that it influences the development of various organs and tissues, and it developmentally affects the immune system. But these endocrine effects are mediated by the serum levels of vitamin D, but these immune and developmental effects are linked much more to the level of vitamin D in the tissue, which is not something that you can measure directly. You can only measure what's in the serum. And the other important point here is that vitamin D is known from the literature to mediate all aspects of pregnancy and postnatal immune function, everything from implantation of the egg in the mother into the uterus, and how that implantation is modulated between the mother and the fetus, because the mother and the fetus have different immune systems. So this is all just background information to getting the VDAR trial funded. And this is actually described in this paper at the lower right-hand corner, but the trial itself is visually depicted here. So we enrolled pregnant women between the 10th and the 18th week of gestation. So they had to be at least 10 weeks pregnant. And we were focusing on women who were at high risk of having an asthmatic child. So we were focusing on women who had asthma or allergies themselves, or asthma and allergies in members of their family. And they were randomized to two groups, 4,000 IU of vitamin D plus a prenatal vitamin, or a placebo and the prenatal vitamin. So 4,400 IU total in the treatment group, 400 IU in the control group. They were monitored with questionnaires and blood draws and cord blood, and the pregnancy outcomes, and the mothers were followed up at 1 year, and the children were followed up at yearly from birth until age 11. The trial itself was really the treatment, and the trial itself was confined to the mother. We didn't we gave vitamin D to the children, but it wasn't mandatory that the children took the vitamin D. So this is really a trial primarily of vitamin D during pregnancy, not postnatally. And the first finding of the trial, which was published in the 3-year follow-up in JAMA, which is shown in the lower left-hand corner here, was that depending on what the target level you were shooting for in the serum of the mothers, that the 4,400 IU dose, which was the treatment dose, only resulted in 75% of the pregnant women achieving a target serum level of 30 nanograms per ml. So this dose was probably too low. The reason we chose this dose is because Dr. Bruce Hollis, who was a consultant for this study, had a standing IND from the Food and Drug Administration that allowed us to use this dose, and we didn't have to apply for a different dosing. I'll come back to this difference between the 20 nanograms per ml is sort of what the Institute of Medicine says you need for bone health. The 30 nanograms per ml is what we were shooting for in this study because we thought that was what was needed for immune health. But we'll come back to whether this was an adequate dose and whether we reached what the effect of these target levels were in terms of our outcome. But suffice it to say that based on this information, not all the mothers achieved the 30 nanograms that we were trying for. So then we pre-specified on clinicaltrials.gov a standard intent to treat analysis. And that means that we were comparing the treatment group, the 4,400 IU group, with the control group, the 400 IU group. And the results of that standard intent to treat analysis are shown here and were published in this original follow-up paper in JAMA. And you can see here that these are survival curves indicating the proportion free of asthma or recurrent wheezing in the treatment group in red and the control group in green, showing that there was a reduction in the asthma wheeze in the treatment group of about 20%. And that this had a p-value of 0.051, which is very close to what is considered to be statistically significant, which is p.050. Now, just a comment about the intent to treat and the p-value. So the p-value is an indication of how likely you would see a result this extreme by chance alone. So 0.05 would indicate that 5 times out of 100 you could achieve these results by chance alone. But obviously these p-values are a continuum, and p.051 is really not different from p.05. But in the eyes of journals, they take that p.05 as sort of a fixed point. What's also of concern to us was that the reduction that we saw was only 20%, whereas in observational data, the two studies, observational longitudinal studies that we did that were not clinical trials, we saw about a 50% reduction. So we weren't seeing as big a reduction here, and that was of greater concern than the actual p-value was to us. So, and again, the journals take very seriously what you deposit in clinicaltrials.gov as your essential analysis. And not knowing any better, we use the standard intent to treat analysis, and I'll subsequently explain why that maybe was not the best choice.
So just to interrupt real quickly, that p-value is what's called statistical significance. And in terms of how the journals interpreted it versus how the public then interpreted what the journals said, do you feel like that even that 20% reduction should have gotten more attention than it did or been taken more seriously, but because there was not that statistical significance, do you feel like that affected how this research was viewed?
Well, I think that what I'll say is that the journals were very strict about what we could say and what we couldn't say. And so because in their view, P.051 was not significant, we had to write the paper as if it was a null trial, a negative trial.
Exactly.
But there are three reasons why this result at 3 years that was published in JAMA was not statistically significant. And the first is that we didn't give enough vitamin D. So only 75% of the trial participants achieved the level of serum vitamin D that we wanted to get, which was 30 nanograms per ml. So that clearly biased our results in the direction of the null. We didn't give vitamin D early enough in pregnancy. It would have been very difficult to do this earlier in pregnancy because it would have been hard to enroll pregnant women at an earlier stage. But there is clearly evidence in the literature that vitamin D is important for successful conception, implantation, and maintenance of a normal pregnancy in a wide variety of mammals: humans, mice, rats, monkeys, and dogs. There's also this finding that Bruce has published that immediately upon conception, the active form of vitamin D, the 125 OHD levels in pregnant women increased tenfold over the baseline. And that it happens right at conception, not at the 10th to the 18th week. And then vitamin D influences branching morphogenesis, and there's data from mice and rats and humans that branching morphogenesis occurs in this window between 7 and 17 weeks gestation in the human. And then the final point is that nutrient trials are fundamentally different from drug trials, and that vitamin D was present in the subjects in both the treatment arm and the placebo arm at the time of randomization. So when you look in the paper in JAMA, the baseline level of vitamin D in the control group was exactly the same as it was in the treatment group. And that's a huge null bias, because when you do a drug trial, you're comparing drug in the treatment group to no drug in the control group, whereas we clearly had contamination. And 0.3 combined with 0.2, that vitamin D that was present in the control group was clearly influencing the development of the lung and the immune system in those patients in the control group prior to the trial. So the first thing we did to attack this problem was we did a meta-analysis. So we combined, because we were concerned about this fact that we only had 20% result from the trial. And we knew that if we combined our results with the only other trial that was available was this COPSAC trial, that just combining, they used 2,000 IU of vitamin D given at 20 weeks. So they used a lower dose later in pregnancy, but they also saw an effect. So we combined our results with theirs in two different types of meta-analyses, a fixed effect and a random effect meta-analysis. And just by increasing the sample size, this is now statistically significant. We see about a 25% reduction in asthma wheeze at age 3 years when you combine the two trials. But that estimate is still half of what we were seeing in the observational studies. So then we did the second adjustment, which was to stratify the results by the level of vitamin D at entry into the trial. So this is what would be called a stratified intent to treat analysis. So that this means that we were accounting for the vitamin D in the control group in the analysis. And when you do that analysis that way, and you show that we can show very clearly that not only is the result statistically significant, now we recover almost exactly the same effect that we saw in the observational studies, about a 50% reduction in asthma wheeze in those who had an initial vitamin D that was elevated at baseline. And then the final point, which is shown down at the lower left-hand quadrant of this slide, is that the probability of asthma wheeze in the offspring was directly proportional to the initial 25-hydroxy vitamin D level, and that if we had levels that were higher than 30, up in the range of 50 or 60, we would have seen a markedly increased reduction in asthma wheeze. So this slide addresses all three of the concerns that were raised in that previous slide. What would happen if we gave a higher dose? That's what I just showed you at the lower left-hand corner. What would happen if we adjusted for the vitamin D that was in the control group? That's what's in the upper right-hand corner. And what about just increasing the sample size to get a significant p-value? So we did more work on the risk of asthma wheeze as a function of either the vitamin D level in the mothers at 10 to 18 weeks, shown on the left-hand side, and 32 to 38 weeks. And again, you can see here that there's this linear relationship where the higher the vitamin D in the pregnant woman at either 12 to 18 weeks or 32 to 38 weeks, the lower the risk of asthma wheeze in their offspring. Again, suggesting to us that higher doses than the 4,000 IU would be better. Now this slide is important because it shows two different measures of lung function that we measured at age 6 in a subset of the children in the trial. On the left-hand panel, you've got the airway resistance plotted as R5 plotted against age, with the low vitamin D group being in red and the high vitamin D group in blue. And so here, lower resistance is better. And then if we actually look at the forced expiratory volume in 1 second, which is the standard measure of lung function, in the right-hand curve, you can see that the blue is the higher vitamin D compared to the lower vitamin D in red. So you had lower airway resistance and higher lung function if you had a higher vitamin D during pregnancy. So this, you can't measure lung function in children until the ages of 4 to 6. But these results are almost certainly a result of the fetal programming of lung development that occurred in utero, but demonstrating that higher vitamin D in utero resulted in higher vitamin D in utero resulted in better lung function in the child. So if we were to summarize the VDART results, pregnancy is a continuum. Vitamin D is necessary at every stage of pregnancy and beyond. Vitamin D sufficiency in early pregnancy has a greater effect on asthma outcomes than vitamin D in later pregnancy. Nutrient trials are fundamentally different from drug trials because there's contamination of the control group. There are methods that you can use, such as controlling for that baseline level of the nutrient and still doing an intent to treat analysis. Level stratified intent to treat analysis suggests congruence between the observational results that we saw and the clinical trial results, and the effects of vitamin D are statistically significant at age 3 and at age 6 for asthma wheeze and for lung function at age 6. I'm going to stop with the slides at that point, and maybe we can go to your questions at this point.
Okay, that sounds
But
good.
that's a fairly succinct summary of the trial. Something about intent to treat, something about p-values, but why the analysis that we did seems to suggest that vitamin D is in fact significant and effective in pregnancy. Now, I know one of the questions you wanted to ask that from your list is, what do I think the optimal dose of vitamin D is in pregnancy? And what do I think is safe? I mean, we clearly know from studies in the literature that doses up to 6,000 IU are safe and not associated with any adverse side effects. Now, these are studies that have not been done in the United States. So the highest dose that has been used in trials in the United States has been the 4,000 IU that we used in VDAR. But there is some studies that have been done internationally that have used up to 6,000 with no side effects. And what I would say is, based on those effect curves, that you're really shooting for a serum level in the mother of between 40 and 60 nanograms per ml, which was achieved, maybe by only 10% of the VDAR trial participants.
Mhm.
But that if you were to achieve that level, I don't think there'd be any side effects in the mother, and B, you would probably have the optimal dosing to prevent asthma in their offspring.
Right.
One of the other questions that you asked was, what about preterm birth and preeclampsia? And I would say that our study was underpowered to look at those two outcomes. We specifically screened out women who had prior preeclampsia from being considered to being in the trial. But I think if you take a look at the literature as a whole, I would say that there's quite strong evidence to suggest that preeclampsia can be prevented by vitamin D given to pregnant women. The evidence is a little bit less good for preterm birth, but I think one of the reasons for that is because of a novel finding that we've just discovered from analyzing data in the VDAR trial. There's confounding by body mass index in pregnant women. If pregnant women are obese when they start their pregnancy, then vitamin D is much less effective at preventing preterm birth, preeclampsia, and asthma.
Mm-hmm.
No one really knows the reason for that. It's an extremely interesting finding. We've just submitted a paper to American Journal of Clinical Nutrition on this. We have a bunch of different omics data that we're going to analyze to try to understand exactly why that might be. But I think it's an extremely provocative and interesting result.
Now,
Um,
is that also true when you're looking at the serum level, or is it only true when you're looking at the dose given?
um, it's true when you're looking at the serum level. Yes.
Interesting. Okay.
Yeah. Yeah.
All right. Yeah, we Grassroots Health did a study with the Medical University of South Carolina, working with Dr. Carol Wagner.
Yeah.
And we implemented, as part of the standard of care for all prenatal patients, vitamin D testing at initial visit and all the way through, with the goal of achieving a vitamin D level of at least 40. And the dose was chosen based on that. And we did find, of course, comparing by serum level, which I'd like to ask you a little more about soon, but compared to the women who remained below 20, those who achieved a vitamin D level of at least 40 had about a 50 to 60% reduced risk of preterm birth. And the risk reduction was even greater among those women who had had a prior preterm birth. But that's interesting that you're saying that the BMI starts to null that effect, even if you're looking at the vitamin D level and not just the intake.
Yes, yeah, it is. It is interesting, and I don't think that we understand exactly what's going on there. It's a much stronger effect if the women are not obese when they
Mhm.
start the pregnancy. Um, but I think the point about serum levels is that I think that it's my view that what really matters is something we can't measure, which is the level of vitamin D in the placenta, in the fetus, in the tissue, because that's the level that is actually influencing fetal programming, the development of the fetal lung and the fetal immune system.
Mhm.
Now, this isn't part of the trial. I had more slides on this that I didn't talk about, but we've gone on and done a lot of genetic and genomic work where we've demonstrated that one of the genetic mechanisms by which vitamin D is influencing the development of the fetal lung and the fetal immune system is by increasing levels of sphingolipids in the fetus. Sphingolipids are a necessary component of organ development, and they're necessary for the development of the airways and alveoli of the lung, but they're also necessary for the development of the normal immune system. And the way vitamin D works is it binds to vitamin D receptor binding sites on genes that are critical to asthma and lung development to enhance the production of these sphingolipids. So not only is there clinical trial data to suggest that vitamin D is having a significant effect here on asthma, but there is also molecular and genetic evidence that this is having an effect.
Right.
So I think that this additional genetic information was published in a paper that we published last year in eLife. And I think it's significant because it supports what we see in the trial. Now, the final set of questions that you asked, which I think are, very relevant, is why has this trial had relatively little impact on changing clinical practice? Uh,
Correct.
um, and I think I don't have a definitive answer to that. I don't know exactly why this is true. I think that uh, uh, um, the people who would have to change what they do are obstetricians in this country. Uh, um, and so getting this information in front of them, why this has not had a bigger impact on the Endocrine Society or the IOM, I can't say. I think that this idea that nutrient in the control group is a null bias is not understood by people. And I think this idea that what you're really looking at here is tissue levels that are important, not serum levels. That idea is not well established in terms of clinical practice. And I think that although there is safety data for dosing higher dosing than the 4,000 IU, it's not from studies in the United States. So those are all factors which I think are playing into why people are not potentially buying into this. But I do think that the other feature here, which has been written about by some very well-known nutritionists like Walt Willett, who was a friend of mine, is that I think vitamin D deficiency, particularly during pregnancy, is one of the most significant causes of health disparities in the United States. Because all of the diseases that we're talking about, childhood asthma, preeclampsia, preterm birth, are much greater in the African American community than they are in the Caucasian population. So, and vitamin D deficiency is the most common vitamin deficiency in the world. And vitamin D deficiency in pregnancy is much greater than people have realized because of the tremendous increase in requirements that the pregnant woman has, because she has to have vitamin D both for herself and for her fetus. The other thing that we didn't discuss here and was not part of the VIDAR trial, but it is also a significant null bias, is that fetal lung development and fetal immune system development don't occur in a vacuum or just during pregnancy. They also are important during the first few years of life. And so giving vitamin D to the newborn is also critical. And this is another area where the recommendations are probably half what they should be. The recommendations are sort of on the order of 400 IU for babies during the first year of life. It probably should be 1,000 going up to 2,000 at age 2 and maybe 3,000 at age 3 and staying at 3,000 after age 3, whereas most children are getting nothing. So I think that I'm as I don't know what it would whether it would take a bigger trial in the United States or what it would take to actually get people to view pregnancy as being a different state from what people need during other times in their life, and trying to get pregnant women the dosing of vitamin D that they really need. And I do think that there are important health effects here that go well beyond the diseases that we've talked about. I think there's an impact on the baby's weight and obesity. I think there's an impact on brain development in the baby. I think there's an impact on heart health in the baby, none of which we touched at all in the VIDAR trial.
I've even heard of a relationship between the incidence of cancer later on in that baby's life.
Oh yeah, I mean, I think that there's no question that a lot of fetal programming influences diseases much later in life. So if you have abnormal fetal programming, it could potentially be detrimental in a lot of different
Right.
ways.
And I'm really glad that you brought up the increased conversion of the vitamin D into 125, because one of my favorite points to bring up that even others in the research or medical community are unaware of is that the level of 125 that a pregnant woman achieves would be fatal to anybody who's not pregnant. Isn't that correct?
Yeah, that's something I actually don't know. I didn't I didn't know that. I mean, most of what's measured in all of these studies is the 25
Mhm.
OHD, not the 125,
Mhm.
because the 125 has a half-life of minutes to hours. So we've sort of concentrated on 25 as a proxy for the 125, as a proxy for the tissue levels of 25. I
Yeah,
think one of the key points is that both vitamin D and 25 OHD are fully diffusible across the placenta and the fetus. And so, and immune cells, every type of immune cell has the full biochem and the placenta has the full biochemical machinery so that if it could take vitamin D or 25 OHD and turn that into 125 OHD. So I think that if the fetus is provided with vitamin D or 25 OHD, then everything's going to be okay because the biochemical machinery to make the active form, the 125, in the tissues, in the placenta, and in the fetus are there.
right, right. Yeah, Dr. Hollis likes to bring up a particular incident where a pregnant woman was told her vitamin D levels were incredibly toxic. The doctor was accidentally looking at the 125. Well, not accident, but they were looking at the 125, and she reached out to Dr. Hollis, and he's, no, that's normal during pregnancy, but not normal at any other time. And
Yeah.
that to me is a way of the body indicating the incredible need of vitamin D for whatever processes are occurring in pregnancy.
Yeah, well, I
Um,
think that the marked increase in bulk transport of vitamin D immediately upon conception, there's no question that the pregnancy-related needs are, you know, 5 to 20-fold greater than what a person would need it. Because what's happening is the mother is modulating fetal development, and she needs the vitamin D for the developing fetus, but she also needs the vitamin D for herself. And she's also controlling her own immune system to prevent rejection of the baby, which is all being mediated by vitamin D. So just a lot more physiologic need during pregnancy, which
mhm.
again, I think most of the regulatory bodies have no clue. I mean, the US DA recommends 600 IU of vitamin D for pregnant women, whereas what Bruce and I would say would be a minimum of 6,000. So
Mhm.
it's like a totally tenfold different in
Right,
terms of what's needed.
right. So, one other curiosity, have you been able to measure to see if there is a correlation between vitamin D levels in the tissue and the blood, since you mentioned it's the tissue that is more important in terms of the need and the concentration during
Yeah,
pregnancy?
we have a paper now. This is not something you can do in humans because you can't get tissue from living humans to measure. But we have done a mouse study where we've got this, and we have a manuscript in preparation on that. Um,
I'll have to get that from you. Um,
Well, it's not, we haven't submitted it yet, so it's going to be a while before that's ready to be submitted. But we were able to do measurements in a variety of different mouse organs in addition to mouse serum. in pregnant mice. So we've got a lot of data there.
So, kind of going back to the evidence, you mentioned that it's most important for the doctors to get this information, learn to understand it, and then make their own decisions in practice instead of maybe relying on the organizations in charge of making the guidelines and all of that. First of all, what are your thoughts on organizations like the Endocrine Society and the IOM relying so heavily on randomized controlled trials, which your trial was a randomized controlled trial, but because of the p-value and other reasons, it may have not been considered. But in terms of creating guidelines and suggestions for nutrients for the public to follow, for the doctors to follow, what are your thoughts in relying so heavily on the randomized controlled trials, especially when there are other types of studies like observational studies, mechanistic studies? You've discovered exactly how the vitamin D works in some cases, what it's doing in the body. And yet that's not even taken into consideration when these guidelines are created. What are your thoughts and what advice do you have to give?
Yeah, that's a really good question. I don't know the answer to that. I think that the medical community tends to be overly conservative, even in the face of clinical trials. An example would be uh, 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 um, feeding peanuts to little babies to prevent peanut allergy. Even though there was a trial that demonstrated that this worked, you couldn't get allergists and pediatricians to actually give the babies peanuts to prevent peanut allergy. So I think that ideally people would use the totality of the evidence, not just clinical trials data. I think that the tendency, I think we know enough so that we could design a much better clinical trial that could, I think, show statistical significance. But and I even believe that doing such a study would be far less than the cost of not giving pregnant women a vitamin D. But I think the totality of the evidence would be a better way of looking at this than just relying solely on clinical trials. Another example where clinical trials, I think, have missed the boat is that if we're right about this BMI effect, that all of the trials that have looked at preterm birth, all of the meta-analyses are incorrect. They should be stratified by maternal BMI at the start of pregnancy and then reanalyzed. Because if you did that, you would see that the effect of vitamin D is really being confined to those women who have a normal BMI at the start of pregnancy. And excluding these obese women would give a much clearer result. It would probably mean that vitamin D was statistically significantly in these meta-analyses for both preeclampsia and preterm birth. So I'm a fan of the totality of the evidence, but then it becomes a question of which experts you have and who is. I mean, many of the vitamin D experts were excluded from that IOM panel, for instance, and I think there's a clear distinction between the endocrine effects of vitamin D related to bone health, where you don't need a high serum level, and the autocrine paracrine effects of vitamin D, where tissue levels and a much high. I mean, I think that even people like Bruce and other experts were initially pushing 30 is enough. 30 is not enough. You know, it ought to be closer to 60. If you ask Bruce what is his serum level, he'll tell you it's 60.
Mhm.
So I think that, and there are no side effects of being at 60. So you're not going to get kidney stones or have any other health problems if your serum level is 60 as opposed to having a serum level of 30 or 20.
Yeah. No
So
negative side effects, a lot of potential good effects.
exactly. So I think that you know we've been and 60 is sort of the level that what you see in people who are regularly sun exposed for an extended period of time. So it's much more the physiologic effects of what we've seen for the last 100,000 years, not what you're seeing over the last 100 years, where people are basically naked mole rats indoors all the time.
Yeah.
So I don't know if things are going to change, but it is interesting that there's such confusion about what the right intake should be. And I think pregnancy is really a form first example of why you really need a lot more.
Yeah. Could you just briefly describe if you were to redesign another trial, how would you do it differently, or what advice would you give to, the up and coming vitamin D researchers who would like to
Yeah, so
redo this?
I think that because vitamin D is critical for conception and may be important actually in the whole conception process. I'll describe the ideal study. The ideal study would be to get a group of women who wanted to get pregnant, randomize them to high vitamin D and 400 IU or no extra vitamin D, and then follow them through pregnancy. But there would be a lot of loss, right? I mean, you'd have to have a really large sample size, and getting women who want to become pregnant is very complicated.
Mhm.
So another way to do it would be to enroll pregnant women very early in pregnancy. In other words, not at 10 to 18 weeks, but at 4 weeks, if you will, or 5 weeks. The first hint that they were pregnant and enroll them then. But again, you'd want to have a difference in the vitamin D level at baseline. So you'd want to make sure that your control group was people who had on average a vitamin D level of 20, whereas the treatment group was really at 40, and have that be from relatively early in pregnancy. And then the other piece would be a higher dose. So 6 or 8,000 IU of vitamin D in the treatment group versus at 400 IU in the control group. I don't know if such a trial would be ethically doable in the United States. You'd have to get special IND approval from the FDA. Maybe that'll be easier to do under the Trump administration than it would be now. But you'd have to give a higher dose. But those would be the big things that I would. The other point that is worth making is that the effect estimate that we saw in VDART, even though we were, the Institute sort of said, focus on women who have asthma and allergies. Even when we did that, the effect estimate that we saw was what we saw in the general population. So we were basic. I don't think we lack generalizability of the results from VDART. I think VDART actually shows that this would work in a general population sample of pregnant women as well.
And
I
can
mean,
you just,
there are other ways to go about, I mean, you could try to educate the American public as opposed to just doctors. But I really do think that the key people here are OBs
Mhm.
or nurse practitioners who are taking care of women early in pregnancy and getting them on high dose vitamin D early on. I think that's probably the critical public health intervention here.
Right, right. And just to quickly define why you need an IND with something like vitamin D.
Really good question. I don't know that you absolutely do. I mean, it's considered a drug. There are certainly people who think that uh, uh, there could be side effects, negative side effects of doses of 6,000 or 8,000. I don't believe that, but INDs are traditionally used when there's concern about potential side effects of the medication.
Mhm.
That's the reason for an IND. Whether the FDA would actually require an IND for 8,000 IU, I don't know. It'd be a negotiation between an investigator and the FDA as to whether that was required.
And so that would be necessary for a randomized controlled trial, but in an observational study where, I mean, honestly, I take every once in a while, I'll take 10,000 IU a day. I usually take 5,000, but I know where my level is. And case being, I can choose my dose, you can choose your dose, and we could enroll women who are choosing their dose. And but that type of observational study, excuse me, wouldn't necessarily be reviewed in it would be reviewed in a different light than a randomized controlled trial.
Right. I mean, I think if you were going to spend a lot of money on this, you'd probably want to do a real trial because that would be the most convincing.
And about how
And
much money would it take?
well, back in 2008 or seven when we started VDART, VDART cost 10 million. I think you could probably do it for in today's dollars for 10 or 11, $12 million. It wouldn't be, I mean, relative speaking to how much money you save by preventing all these complications, it's incredibly cheap.
Mhm,
It's extremely cost effective.
mhm.
So I don't think the amount of money you would be spending would be untoward relative to that.
Right.
Uh,
A lifetime of savings.
yeah,
But it's finding somebody to back the initiation. Dr.
exactly.
Weiss, I really appreciate your time. Are there any final thoughts, any key takeaways that you want to share before we close today?
No, sounds
Pretty
good.
much covered it all. Okay, all right.
I can send you those slides if you want.
Yes, please.
All
Yes,
right,
I would
I will
appreciate
do.
that. Okay, all right. Well, thank you
Great.
so much
Yeah,
for
great to
joining me today.
great to talk to you.